just common things that I see in the office, not only in the summertime, but also all year round. But I did tailor the presentation a little bit more towards the summer. So without further ado, here we go. So Savannah already went over stuff about me. These are the offices that I practice at. My main office will be the Homedale office, but I'm also in Ocean and Freehold. We have 3 other offices, Brick, Barnegat, and Monroe as well. I just don't go to those offices. Okay, so affiliations, we did that already. That's my family, my 3 kids, Caden, Callie, and Quinn. There'll be more pictures of them to come. So a little quick anatomy of the foot, and we're not going to bore you with this. It's just to show you how intricate the foot is. 26 bones and 33 joints. So most people think that it's, maybe 6 or 7 in there. There's 26 in there. So lots of potential issues. So one of the most common things I see, especially in the summertime, as soon as people go into sandals, I see it start coming through the door every day, left and right. Heel pain, plantar fasciitis. So they're closely related, the 2 of them. We'll get into it. What's plantar fasciitis? It's really inflammation where the plantar fascia, which is this long, flat ligament, attaches on the very bottom of our heel. So if you have pain on the bottom of your heel, could be related to that. On the back, we'll get into that in a little bit. That's more likely in the Achilles area, which is very different. So what causes it? A lot of people who stand all day, increase in weight, or if you're just heavy, that adds to more stress on the foot, increase in normal activity, foot type. Certain people have certain foot types where they're just born a certain way and put more pressure on that area. And then actually the Achilles and plantar fascia are linked together. People who have tightness in their calf and their Achilles often compensate, and their foot stretches more when they weight bear. How do I make this diagnosis? The clinical examination and the history is very important for this. But we also will take x-rays, and oftentimes people have a heel spur. On the bottom of your foot, just because you have a heel spur, it doesn't mean it has to hurt, and it doesn't mean you have plantar fasciitis. But what it does mean is that you've had the plantar fascia pulling, probably more than it should, for an extended period of time, and the body has actually reacted to that pull and created new bone, and that's our heel spur. If we're not sure still what the diagnosis is, an MRI and ultrasound will definitely show it, as those are more advanced techniques. The MRI is more of a gold standard if we're looking for it and unsure. How do we treat? Everyone who comes into my office for plantar fasciitis we'll go over a stretching regimen. I might give you a handout, demonstrate some stretches that you'll do every day. When it gets to a point that people are coming to the office, they're usually coming in because their pain's pretty severe. They're not coming in because it's a 1 or a 2. They're coming in because it's between a 7 and a 10. And then at that point, a steroid injection does make sense to decrease the inflammation. But at the same time, that's not all we're doing. We're then putting on a stretching program. There's something called a night splint, which I'm going to show you a picture of, that actually keeps the foot stretched while non-weight bearing. Orthotics can be helpful. Different types of shoe wear, sometimes physical therapy. Ice and anti-inflammatories are simple. And there's other treatments out there like shockwave and PRP. Surgically, I'd say probably 1 out of 10 people who I come across with plantar fasciitis, heel pain, heel spurs, might go into surgery. And there's different techniques. The technique that's been around for a long time is a plantar fascia release, also called the fasciotomy. And now there's some newer techniques where we actually don't make an incision for something like the Topaz, which is a micro ablation technique, which I'm going to show you some pictures of in a little bit. So plantar fasciitis is a really good model. The one on the right, actually the one on the left does too. They both have heel spurs, but it's found that the pain itself is not caused by inflammation of the plantar fascia. That's what the name would infer, but it's actually caused from inflammation of the bone. So the bone has an outer lining to it called the periosteum, and the excessive pulling on it creates the inflammation. There's a good diagram kind of showing an inflamed area at the origin where it starts. So stretching, this is just a couple of the ones, and these are 2 that I always tell people to do. The first one, you're just basically taking a band, or you can improvise with a towel, and you're pulling the forefoot until it stops, and you're just holding it there 20 seconds. and you're repeating the reps 3 or 4 times. And I have people do this with their knee extended and bent, and it actually targets different parts of the calf by doing it that way. We've all seen people do the runner stretch. You can do other things like rolling it, sometimes with a ball or a frozen water bottle. And physical therapy will have even more things that they'll get into. This is a picture of a night splint. There's a lot of different night splints out there. If you go on Amazon, you'll see 10 different varieties. This is similar to the one I use in the office. I like it because it's lower profile than most, and it still does the same thing. It's just keeping that foot from going into a downward position, which is called plantar flexing. It's literally just keeping it there stretched out, and that's shown to be beneficial for plantar fasciitis when you're stationary. Uh-oh, it says unable to sync the page update. Let me try again. Just kind of lost my presentation. 1 second.
Hang on, let me see why we can. Sorry, everyone, just give us 1 minute. Technical difficulties.
Can you see my presentation or no?
It's not coming up
Yeah,
right now. I don't know why this whiteboard is opening.
Do you want me to close it and maybe try to go back
Yeah,
in, or
I'm trying to see it. If I still preserve this. You click share one.
let me see if it'll do it now. Okay, I think it's going. I think it's working. Okay.
Okay, I see you. There we go.
Yeah. All right, we'll
Sorry
get back.
about that, everybody.
Technical difficulties. All right, so we were talking about plantar fasciitis. Now we're going to move on to the Achilles, which is generally going to be pain in the back of the heel, and it could be where the Achilles actually attaches to the heel, or it could be higher up. Achilles tendonitis infers that there's inflammation. Tendinosis is its cousin. It means it's thickened and scarred, and that means you've probably had this problem for a longer amount of time, and you can actually start to feel a bump on the back of your Achilles tendon. Diagnosis, clinically, it's pretty easy diagnosis, but sometimes we want to see just how bad it is, or if you have small tears, or how bad the tissue is degenerative, and then we'll get an MRI. Treatments for initially, we might rest you, and then we'll get into stretching. We'll do shoe changes. Ones that have more of a heel are actually beneficial than flat or barefoot walking. Orthotics or heel lifts can be beneficial, anti-inflammatories, and there's different surgical techniques for people who fail all that. There's a good image because it shows on the left Achilles tendinosis, which is the thickening. We can actually see the tendons bulging there. And then on the right, this person has a giant heel spur. So we talked about heel spurs 2 times now, one on the bottom down there, one on the back. The problem with the ones on the back is they don't do well. They tend to rub on the back of someone's shoe, and they're very painful, and they're hard to basically offload because most of our shoes have backs to them. So a lot of times we'll have someone try to wear a backless shoe that is also raised. Not always so easy to do if it's 30 degrees out, though. Orthotics can be helpful. For an Achilles problem, we would build up the back of the heel. For someone who has a flat foot, we might build up the arch. There's different uses for orthotics. We do our orthotics in the office digitally. There's a lot of ways to do them. The newest way to do them is probably just to take a digital scan of the feet. And this not only scans the feet, it actually shows us where the pressure is being applied in the feet. And then we use an orthotic lab to actually make orthotics from a digital file. So everyone always asks me in the office, what type of shoes should they be wearing for these problems? You know, plantar fasciitis, Achilles tendonitis. And I do have to say, Hoka's, they've become very trendy, and I'm a believer in them. They are really well-made shoes. While they're somewhat expensive, it's kind of what you get what you pay for type of thing. If you could look at the construct of them, they have these kind of very big soles, and that is helpful for both plantar fasciitis and Achilles tendonitis. And it's really helped a lot of my patient base is these type of shoes versus some of the others. And that doesn't mean Hoka's better than every type of shoe out there. It's not, but it's a good place to start if you're not sure. And I thought this was good too because it's summertime, and I got a lot of people in my office wearing flip-flops, and some people can get away with it, and other people they really can't. And for someone who's got a heel problem, it's probably the worst thing you can do is go around and wear flip-flops. So Hoka actually has their own sandal, and if you look at it compared to their sneaker, it's kind of similar. They have a very similar design on both, and you can still be fashionable in the summer, but wear a supportive shoe. So, and no, Hoka doesn't pay me. I just like their stuff. And that's a look at it from the back. You can see the heel lifts on those. I think that's a pretty effective sandal, and you can mimic that with other brands as well. We talked about Topaz, and I do this in a couple areas. The two big areas are the plantar fascia and the back of the heel and the Achilles tendon. I'm not sure if I have another picture. No, I don't. But what the Topaz does, it's an interesting technique where we don't actually make an incision. With some anesthesia that's done in like a surgery center outpatient, we make little holes, little tunnels into either the plantar fascia or the Achilles tendon using a little wire. And then through the wire, this device is called a Topaz Micro ablation. And that little wand then sits into the hole and it goes down to the target tissue, which would either be the plantar fascia or the Achilles tendon. I actually have a little control that I can hit, and as I hit the control, it uses heat to punch a little hole into the area. So what does that do? It actually breaks up the thickening, the scarred tissue, and it almost tricks our body into addressing the problem. At the end of this procedure, you'll have a grid of holes into the plantar fascia of the Achilles tendon, and your body will then come in and over time fill in those holes, and you get better tissue than what was there previously. I don't tell anyone that this is 100%, we're going to solve all your problems with it, but it's also sometimes a good place to start if you don't want something more invasive. You're not burning any bridges with this procedure, and it's quick and, not non-invasive. Sprains and strains, we see this all year round, but I definitely see it in the summer, and I've been getting a lot of them lately because people are out and about, they're doing sports, and they're on the beach, and they're twisting their ankles and their feet. So what's a sprain? That's an injury to the ligament, and a strain is to a tendon. Tendons attach muscle to bone. This is a quick diagram of all the ligaments and tendons in the feet, and just like when we went over the 26 bones, there's a lot of tendons and ligaments in the foot and the ankle, and there's a lot that can be injured when the foot is twisted.
Wow.
So imaging, how do we figure out what's going on? Obviously, an x-ray is going to show me stuff about the bone. It might show you if you have a break, but it doesn't show me a whole lot else. It might show you those bone spurs. It might show you if you have really bad arthritis. But a lot of times it's got to be stepped up if we can't make a diagnosis from it. Then we have a CT scan. Now we're getting into three-dimensional looks, and that's a much clearer look at bone and cartilage and a little bit of soft tissue. Ultrasound is okay for a more non-detailed soft tissue look, and also obviously for vessels, it's very good. But for my purposes, that's more if I'm looking for a blood clot or something like that. An MRI still remains the gold standard for soft tissue. Very detailed three-dimensional view. It's going to show us bone, soft tissue, cartilage, tendons, ligaments. I like to say MRIs don't lie, and it's pretty much true. I mean, most of our diagnosis can be made with an MRI, not all. So some people are claustrophobic, and there's obviously, most people know there's open MRIs now. So, some are better than other, and some of the quality is better, but this is an example of one where, this is often the case. They tell you to listen to some music, you put your leg in, you zone out, and you get your MRI done. So the ankle sprain, I mean, it's kind of the old mnemonic, RICE, rest, ice, compression, elevation. That's the initial treatment. We'll usually immobilize something like a walking boot or a brace, depending on the severity. Ankle joint arthritis kind of goes with all arthritis. I mean, it's just a damage to a joint, damage to the cartilage. So the cartilage is the lining of our joint. So whether you have it in your knee, your hip, your back, your foot, your ankle, it's basically damaged cartilage. You might feel pain, stiffness, limited motion, swelling. You might have a grating sensation. That's not a good sign. And those spurs, they're often on joints. We'll see spurs forming. Risk factors, obviously, as you go through life, the more you do, the more you might break down your joints. And even good cardiovascular things like runnings have issues with joints. Obviously, the heavier you are, the more strain on the joints. There might be an injury. Occupation, I see a lot of construction workers and mail carriers and people who put a lot of wear and tear on their foot and ankle who accelerate the process. Genetics, gout, those are other obviously things that could occur. Testing for arthritis, x-rays do show arthritis. They might not show us just how bad, and then we would go on to something like an MRI or a CT scan. Sometimes I'll even give a diagnostic injection, meaning you could do it with or without steroid, and you would determine whether or not they get relief in the joint. So you could just inject lidocaine to numb it, or you could inject a steroid to make it feel better, or both. And even if you get relief for one day, if I inject it into the joint, then I know your problem's coming from the joint. Treatments for arthritis, anti-inflammatories, physical therapy depending on the severity, bracing, injections, arthroscopy, and the worst case would be some type of fusion. That's a pretty standard ankle brace. We use that a lot for the sprains and strains, maybe even for a little arthritis. People tend to do well with it. It's low profile. It can fit in a sneaker. Arthroscopy, so if you damage the cartilage, sometimes it is repairable, especially if it's a single defect and it's not your whole joint. Then we go in, make 2 little holes, just like they do in the knee, and we do the same thing in the ankle, one for a camera and one for instrumentation. The camera in the ankle is very small, 2.7 millimeters. I actually use one that's even smaller, called a nanoscope, which is under 2 millimeters. So this is a well-tolerated procedure. It's outpatient. You do have to be non-weight bearing for a period of time after. And we do restrict physical activity after, because a lot of times we're going in, clearing out inflammatory fluid, and then also potentially repairing the cartilage. And there's a good article in the Journal of Bone and Joint Surgery, which showed arthroscopic repair of cartilage lesions yielded a good result, a good to excellent result in 93% of people. But, the caveat is if you have full-blown ankle arthritis, you can't have an ankle scope. If you have a single lesion, we can fix it. Bunions. So obviously we get a lot of bunions, but they're more noticeable when people are wearing sandals in the summertime. That seems to be when more people come to me, when all of a sudden they become concerned about the looks of their feet, and they do hurt. It's not just aesthetic. What causes bunions? A lot of people believe that it was the shoes they wore when they were 20, but that is not the cause of bunions. The cause is really hereditary. The shoes you wear and the activities you do can definitely accelerate the process, but plenty of people who can wear terrible shoes and do terrible things to their feet and not develop bunions. So in my practice, it's anything from wearing wider shoes to orthotics to types of splints to surgery. And this is a good look at a bunion. So again, with the bunions, there's some misconception going on. A lot of people come in, they say, well, I have this big bump of bone that's overgrown on my foot. Can you just shave the bump off? Sometimes, but a lot of times, no. If you look at that person's foot in that x-ray, you can see it's not just a big bump of bone. There's a big deviation between the second metatarsal, which is pretty much parallel with the third and the fourth and the fifth, and then this person's first metatarsal is out to right field. And what you feel is the first metatarsal head pushing up on the skin. So yes, there is a little overgrowth of bone here, but just shaving that actually does not correct that deformity properly, and the recurrence rate is very high. So one of the main questions I get with people coming for bunions is, my friend got it done and theirs came back, or is it a terrible experience, or whatever it was. And there's a lot of probably wrong procedures being done for bunions. And it's sometimes difficult. You have to figure out what's the best procedure for that patient and their lifestyle. So this is somebody who has bunions and hammertoes, a little bit of a mix there. And then there's different ways to fix a bunion. There's probably some of you have heard of Lapiplasty, which I'm definitely not going to talk a lot about. But a Lapiplasty, is a type of procedure that basically fuses the joint back where those screws are, but it doesn't use screws. It uses plate and screws. But my point here is this one was done with the Lapiplasty and this one was done with 2 screws. It really doesn't matter how you fix it. It just matters what procedure you did and that you did the right procedure for the severity. So the most severe Bunions get these more proximal, which is more towards the middle of the foot procedures where we fuse joints. And it doesn't matter whose hardware you use. Lapiplasty has really kind of inundated social media with advertisements, and patients pick up on it and they ask me about that procedure. It's one of the few types of hardware that people actually bring to my attention. I always kind of laugh and have to explain to them they didn't invent the procedure, and there's other ways to do it, and there's nothing wrong with using that hardware either. Hammertoes, some of you might have hammertoes. There's lots of different reasons. Some are hereditary, some are neurological that develop over time, some are from injuries. Shoes can exacerbate them. Pretty easy to see just clinically, but the x-rays often show just how bad they are. There's all sorts of treatments for them. Unfortunately, none of them are permanent other than actually surgically getting them fixed. Another one that we see a lot in the summer is stress fractures, and this is due to, again, people go into sandals and they're out more. So it might even be in sneakers, but they're out more. So it's usually the person who comes in who's like, hey, I was out in New York City, I was walking like crazy, I went to all these different places, and now my foot is absolutely killing me. And there's risk factors for why you would get a stress fracture. So overuse, of course, but osteoporosis pops up. And I made that in red because as people age, some of this is unavoidable, and some of it is determined by hereditary factors, as well as just being female is a risk factor. Once you go postmenopausal over age of 50, 55, bone density tends to drop. So diagnosis of stress fracture is sometimes difficult on x-ray. It doesn't necessarily show up on an x-ray. Usually it's clinically made diagnosis, and if we want to prove it, we can get an MRI. The most common area in the whole entire foot is the second metatarsal neck area, and there's an arrow to it. And this is often an area of just for pain as well. People tend to have pain if they have arthritis in their big toe joint. They tend to offload right next door into the second, and this second can break down. And a stress fracture is essentially a small, teeny tiny microscopic crack in the bone that occurs because bones, like any other object, have breaking points. So osteoporosis, we just kind of touched on that. What is it? And it's basically that bone mass is lost faster than is created. You might notice that your height is dropped. You might have a stress fracture. People on oral steroids are more prone to them, transplant, and then the big one is the drop in the hormone levels. Diagnosis on x-rays, I can often tell if somebody has severe osteopenia, which is low bone density, or osteoporosis, but a bone density is really the gold standard. And this measures the amount of calcium and other minerals in the bone, usually at the spine, the hip, and the wrist. So I put this fact in there just because people are always concerned about radiation, rightfully so. But the radiation received during a bone scan is actually less than that of a flight from California to New York and back. So it just kind of shows you, I would argue that the bone density test is an important test if your doctor orders it. And yes, there is some radiation, but it's for the right reason. Treatments, they've changed. The bisphosphonates were out for a long time, hormone therapy, but now there's some other treatments, including injections. That's just a quick look at what a bone density looks like. Who should get one? So this is criteria from the National Osteoporosis Foundation. So all postmenopausal women over the age of 65 really should get them. This says who have risk factors, but I would argue already kind of have risk factors over 65. It's a good time to get one. Men with medical conditions, or men over the age of 70, and also men ages 50 to 69 with other risk factors for osteoporosis. Switching gears, diabetes, I think this is important because there's a large basis of diabetic patients, and it's important to realize, when you're diabetic and what to do, and the fact that it increases problems in the feet. Type 1 is now being really called insulin dependent, which is the pancreas not producing enough insulin, versus non-insulin dependent, which essentially means that the insulin's being released, but your body has become resistant to it, and blood sugars are running elevated. Gestational during pregnancy only makes up 2 to 5% of women. The causes, type 1, really hereditary, it's the leading cause, but it doesn't have to be. And non-insulin dependent is more often than not lifestyle related. Diet and exercise are what can help these factors. So what's the criteria? A fasting glucose above 126 might show up on your LabQuest report, but really the gold standard for testing is the HbA1c, which is the average blood sugar over a 3-month period. It's the glycosylated hemoglobin. And this criteria seems to always be changing, but the number is about 6. I put this up there. It says, it wasn't really an insulin shot. You don't have diabetes yet. It was just a warning shot. And I think this is a good comic because it really is true. You know, a lot of people are told, hey, you have borderline diabetes. What does that mean? Well, it means you're pretty darn close to having diabetes. And if you don't make some major changes, you're going to have it. And that comes with a whole host of potential complications of it. One of them being diabetic neuropathy, which a lot of patients who have had diabetes for more than 5-10 years develop it. And poor controlled blood sugar exacerbates the problem, but doesn't have to be the only cause. And you might feel numbness, burning, tingling, shooting pains, weakness. Might not be able to, feel light touches or temperature. And it usually begins in the feet and legs and also in the hands and arms, and it's where the smaller nerve endings are. So that's where we pick up on them first. We can make this diagnosis clinically, but an EMG is a nerve condition test, which can more like fine-tune which nerves are causing neuropathy. And complications can be really bad with neuropathy. And I see a lot of people when I go to the wound care center with ulcers, a lot of diabetic foot wounds, which can lead to infections and amputations. Treatment, there are medications to be treated with. I usually will first, if it's very benign, or not benign, but very mild, there's some homeopathic treatments for neuropathy, including vitamins, supplements like B6, B12, and folate. But as it progresses, those don't cut it, and there are other medications. Venous insufficiency, I put this in here because a lot of people are wondering why their legs swell, why their ankles swell, why they have a purplish tint. And the leading cause of that is venous insufficiency. It doesn't have to be. Basically just means that the veins aren't keeping up with the flow of return flow. Gravity is defeating them. And you might notice you wake up in the morning, not so bad, but then as 3, 4, 5 o'clock hits, the ankles are swollen. The color change is called venous stasis. It essentially means that the blood's pooling there. You might feel cramps. You might get blisters and ulcers. There's other reasons like varicose veins and, of course, blood clots and obesity that could cause it. The diagnosis clinically, but also an ultrasound or venogram is helpful. And then the treatment. The treatment's not necessarily fun because no one likes compressing their legs, but it does help. Elevating the legs does too. Diuretics sometimes, and then also vascular surgeons do what are called venous ablations to shut off, potentially leaky vessels. That's a picture. Some of you might know somebody or yourself who has that, and that's venous stasis dermatitis. Wound ulcerations, there's different types, diabetic being the leading cause, but we talk about venous. There's arterial, meaning you're not getting enough blood flow. Of course, traumatic, which I see a lot of that, especially in the summertime when people are getting injured on the beach and doing all sorts of things. And I put cancer on here because it's an important one. It's important for the treating physician to realize that sometimes this wound that's not healing might have another cause. And unfortunately, from time to time, I take biopsies in the wound care center, and it does come back as cancerous. And even though it's a bad thing, it's important to diagnose that early. So, we get you in the hands of either an oncologist or a plastic surgeon, or sometimes myself, who can treat the problem. Advanced wound treatments, I just put up a quick way that we treat wounds, just kind of touching on some of my wound care and limb salvage that I do. All sorts of treatments that we offer in both the office and the wound care center, with the newest stuff being skin grafts. I'm actually going to get into that just a little bit. There's what are called allografts, which are grafts derived from human tissue that are sterilized and processed, versus an autograft. An autograft is something that a plastic surgeon might take from your thigh and put on your ankle, while an allograft comes prepared and sterilely sealed. This is we didn't really talk much about this, but this is a hyperbaric oxygen chamber. Um, this is a modality that we have at the wound care center for really tough healing wounds. And the idea here is that you're actually simulating going to a depth, almost like going to diving in an ocean where the pressure increases and the oxygen is also increased. So you're actually breathing in 100% oxygen in this chamber at a higher pressure, at a lower depth. And that increases, by doing that, you increase the absorption of oxygen. And for people who are struggling to heal wounds because they don't get enough blood to them, this can be really helpful. That's a picture actually of the allograft, one of the allografts that I use. We use this in both wound care center and also right in the office for certain patients. And this can be really effective to expediting wound healing. So this is, I believe, one of my last slides I put here, recommendations. Check your feet daily, and that's really more for our diabetics, but for anyone. The sooner you kind of diagnose or realize you have a problem, the sooner you can get it treated. Exercise and diet is going to help us with a lot of these problems. Diabetics obviously are in a class of their own as far as criteria they need to be meeting. Proper footwear, and the last one is don't wait. I think for all these issues we reviewed, kind of the sooner you get treatment for a lot of these, the better the prognosis. That's my dog, French Bulldog Littles. That's my youngest, Quinn, with the dog, and that's her new car, which she calls her police car because it's blue. And that's a family pic actually from 4th of July over the Navasink. We went to see some fireworks, and that's it. Questions?
All right, so feel free to unmute your mic and speak if you so choose, or if you don't feel comfortable speaking, in the bottom right hand, there's a little chat bubble. You can type your question in there. I'll give people a second in case they're typing. But again, feel free to unmute if you have a question. Also, I just want to note, since this is being recorded and put online, please do your best to not reveal any personal health information and keep all questions pretty generic. Let's see. You might have gone over everything. The presentation might have just been that good.
It was that good, or they all went to sleep. Oh, what do you think about Crocs? I think Crocs are okay. I mean, I think a little bit like the picture I showed of that Hoka sandal, the Crocs have a bigger sole to them, and anecdotally, a lot of patients enjoy wearing them and say they feel good when they wear their Crocs. So I'm not opposed to them. Which Hoka sneakers do you recommend? Oh yeah. So the Bondi, Bondi, they're more of a running type sneaker, but I like to say you don't have to be a runner to wear running sneakers. They're lightweight, very supportive. They say, I think the picture I put is actually of the Bondi. I'm pretty sure the one I put it up there. I'm not sure where that slide is, but I'm pretty sure that was it. Yeah, I think this picture, if I can, yeah, I'm pretty sure that is the Bondi, Bondi. They have them at Dick's Sporting Goods, Roadrunner. You can order online, whatever.
Wait another minute or two just in case anybody else is typing. Yeah, I pretty much live in my Vans, and I doubt those are good for my feet.
I found Hoka's affected my balance. Yeah, I mean, look, the Hoka's, they have that big sole. They make you kind of rock a little bit more when you walk. So it's not a blanket statement that Hoka's are the best shoe ever. I just think for the issues that I was reviewing, like Achilles tendonitis and plantar fasciitis, they do work well. I was very active in my younger years. Oh, whoops, where did it go? All right, I lost that one. Where did it go?
I got it. I can read it for you.
Okay, yeah, it was quick.
So Cheryl says, I was very active in my younger years, and now I'm feeling it in my ankles, toes, and knees. What is the best thing to do to alleviate the soreness?
I guess the first thing would be to see if it's just that your joints are worn down. So whether it's the knee or the ankle or whatever, you might have done this already, is probably just to see if you have arthritis, because that's kind of what you're alluding to, is that over time these joints started to break down. So I would probably start with an X-ray. As far as how do we treat, it's tricky because if you have arthritis everywhere, it's not so simple. You can't just get rid of it. So um, stretching, strengthening, proper shoe wear, I think those things go a long way. And I also don't think there's anything wrong, if you had a long walk and you're really hurting the next day to take a little, ibuprofen or Tylenol, it's not the end of the world.
We also had, what brand is the nighttime plantar fasciitis brace that you showed?
The one we use in the office is a company called Breg, B-R-E-G. I don't know if you'll find that online. They're a big medical supplier, but you'll find other ones similar. You might find a Breg one, I don't know. Usually they're covered by insurance. Almost all the insurance companies do cover them.
All right, so I think that is, oh, we got one more. So this will be our last one for the
Treatment's
day.
dangerous. That's a good question. So it depends where the cortisone shot is. So we all know, like we've heard, too many cortisone shots are bad for you. But again, blanket statements are kind of dangerous. So if you're in a joint, then potentially it is bad if you're giving it too often, because you can actually cause atrophy of the cartilage if there's too much. But somewhere like the plantar fascia, um, I think you can be a lot more aggressive and give a lot more injections. And somewhere like the Achilles tendon, we would never give an injection because we don't want to cause a rupture. She said on the top of her foot, every 3 months. It's not outrageous. I mean, 4 times a year, it's not outrageous if it's giving you a lot of relief. Arthritis, yeah. Yeah, I mean, it's depends. If it's giving you 3 months of relief, then better than surgery, right?
All right, so I think we're gonna end there. If you do have any further questions, Dr. Hersh is accepting new patients, so you can feel free to book an appointment. Questions, www.cvortho.com, or you can call us at 732-660-6200 to book an appointment. If you hopped on late and missed my little intro, we do these little virtual seminars every other month, and you can find information under the About tab or News section on our homepage on the site. The best way always to stay up to date to all things Seaview Ortho is to follow us on socials at Seaview Ortho on Facebook, Instagram, TikTok, and LinkedIn. You can also listen to the Seaview Ortho podcast on Apple, Spotify, and Amazon. And of course, sign up for our newsletter on our website if you scroll all the way to the bottom, and you'll be notified about events and all other kinds of things. So once again, this is recorded, so if you missed anything or you want to re-watch, that'll be sent to your emails at some point tomorrow. And I just want to thank Dr. Hersh again for giving us a little bit of your time tonight on this beautiful summer night. So I hope everybody enjoyed, and I hope everybody enjoys the rest of their week.
All right. Thank you, everyone, for coming out. I appreciate it. Thanks, Savannah.
Always. Have a good night, everyone.
Bye.